Hello, this is Kim Jong-il. Today's topic is cases of upper second molar extraction. This is a 15-year-old male patient with chief complaint of anterior crowding. The profile is acceptable. In panoramic X-ray, erupting third molars and steeper POP on right side are observed. What does this mean? It means that the mandible is deviated to the right. In frontal photo, lip canting is observed on smile but not at rest. The right side of the lip is higher, and the mandible is deviated to the right as well. In the upper arch, there are unilateral crowding of canine tooth 13, distal rotation of the upper right anterior teeth, mesial angulation of the upper right first premolar, and mesial rotation of the upper right first molar. In the lower arch, there are minor crowding with winging teeth on teeth 31 and 41, and mesial rotation of the lower second molars. There are unilateral crowding on tooth 13, half class 2 canine key on the right and class 1 canine key on the left, and severe crown lingual inclination on tooth 23. As a result, the mandible deviates to the right. ODI is 79, APDI is 76.5, and CF is 155.5. This patient has a class 2 low-angle skeletal pattern. With regard to the E-line, the profile is acceptable. FMA is 25, U1 is over-erupted 5.1 millimeters, UOP and POP are steep, U1 is lingually inclined 104, and L1 is labially inclined 96.5. Due to class 2 malocclusion, the lower incisors are labially inclined, and the upper incisors are lingually inclined. IIA is 134, E-line to upper lip is acceptable. Let's take a look at the patient's problem list. 1. Profile is acceptable, so non-extraction treatment can be carried out. 2. Slight lower anterior crowding can be treated with non-extraction approach. 3. Half class 2. Canine key can be treated with either non-extraction or extraction approach. 4. Due to linguoversion of the upper incisors, non-extraction treatment should be carried out. 5. Class 2. Low-angle skeletal pattern is an indication of non-extraction treatment. The problem with non-extraction treatment is protrusion of the lips due to labioversion of the upper incisors. But there are many problems with premolar extraction treatment, which are severe linguoversion of the upper incisors, high CF value, and likelihood of dished-in profile. In this case, only upper premolars can be extracted. This patient has a slight lower anterior crowding and acceptable profile. Because tooth 18 is in a good condition, tooth 17 can be extracted. During diagnosis, explain facial asymmetry and possible treatment plans, which are U78 L88 extraction and U88 L88 extraction. In order to make the treatment easier, tooth 17 can be extracted. How do many orthodontists treat in case of crowding? They consider the use of mini screw for distalization. What are the potential problems? 1. The upper arch is distorted to the right, and this asymmetry is difficult to resolve. 2. And surgical procedures are required for mini screws. But in mio-orthodontics, strategic leveling and alignment makes finishing easier. In case of half class 2 canine key, keep in mind that open coil spring is used in the upper canine area in order to move the upper first premolar distally. Therefore, upper central incisors, lateral incisors, first premolars, and first molars are bonded first. By using open coil spring in the upper canine area and tight cinch back, the mesially angulated and rotated upper first premolar can move distally. This is why upper second premolar is not bonded at first. Due to lower anterior crowding and linguoversion of the lower molars, Schwartz PBB appliance was used, and the screw was turned once a week. In the upper arch, standard brackets were bonded on central incisor, lateral incisor, first premolar, and first molar. Zöllwartier knee-tie arch wire was used for initial leveling and alignment. And Euro 16 SS arch wire with OCS and tight cinch back was used in the next month. Rest of the teeth can then be bonded. Since space was gained in the lower arch by the use of Schwartz appliance, teeth 31 and 41 can be bonded at the same time. If the lower arch is not expanded, tooth 41 is left unbonded, and open coil spring is used in this area to align step by step. The mesially angulated lower second molar was derotated and uprighted by using open coil spring in the first molar area. The first molars were bonded, the upper and lower arches were re-leveled, and Mio arch wires were inserted. Before moving the upper arch posterior, tooth 17 was extracted. Elastics were used to establish Class 1 canine keys and matching midlines. Mio orthodontic treatment is simple with strategic leveling and Mio with elastics. After treatment, Class 1 canine and molar keys and proper upper canine inclinations were achieved, and profile was maintained. In order to resolve half Class 2 canine key on the right, tooth 17 was extracted to gain space for distalization of the upper right quadrant. Lip canting on smile before treatment was resolved by orthodontic treatment. The treatment took 12 months in total. APDI was changed from Class 2 to Class 1, but CF is not changed much. What about POP? The steep POP due to mesial angulation of the lower molars were flattened by uprighting. As you can see in the superimposition, the entire upper arches move posteriorly. The lower incisors were slightly labially inclined. In post-retention photos after 32 months, well-erupted tooth 18 was observed. In panoramic X-ray as well, tooth 18 was well-erupted and teeth 38 and 48 were extracted. Tooth 28 can be extracted later. These are pre- and post-treatment and post-retention photos. The treatment is not easy if the upper canines are lingually inclined. Therefore, it is appropriate to use open coil spring in the upper canine area to provide some room to adjust the canine torque. The treatment procedure is simple: strategic leveling with bonding on upper central incisors, lateral incisors, first premolars, and first molars, open coil springs on canine areas with tight cinch back, open coil springs in the lower first molar areas, and then Mu arch wire with short Class 2 elastics. If there is no or slight lower anterior crowding, the profile should first be evaluated. In case of lip protrusion, only upper premolars can be extracted. If the profile is acceptable, the condition of upper third molar should be assessed for size, shape, and calcification. If the upper third molars are in good conditions, the upper second molars and lower third molars can be extracted to make the treatment easier. Thank you for watching.